Welcome back. So this is going to cover chapter 46. This is the final part. And in this part, we're going to talk about osteomyelitis, osteoporosis, osteoarthritis, and rheumatoid arthritis. And don't forget the rich man's disease, gout. Okay, follow along with the slides. So osteomyelitis is our first topic. Osteo, when you see that as a prefix, osteo is referring to the bone or of the bone. So osteomyelitis is an infection in the bone. Infections in bone are very difficult to treat. They can really progress very rapidly to even sepsis, septicemia, septic shock, and they can be fatal. They will present with pain at the site. Usually there's some kind of a precursor. So the most typical, diabetics that get wounds and they don't know that the wound is there. The wound becomes infected. It's a localized infection. And then because it's not addressed, it spreads, gets into the bone. And it really is problematic because there's nothing to do besides IV antibiotics, and for a very long time, by the way. Okay, so patient's going to present with pain at the site, swelling at the site, edema, redness or erythema at the site. And as it progresses, it will even display with generalized infection symptoms like fever, general malaise, lethargy, those kinds of things. The only way to address it, there are a couple ways. We can go in and either debride it, and the word debridement really means kind of scraping away or scraping out damaged tissue, and in this case, damaged bone tissue. They can do reconstructive surgery, which is pretty extreme, and IV antibiotics. Palliative therapy, the word palliative, by the way, means we're basically just treating symptoms. So we're not going to be able to fix it because it's gone too far, but because it's causing symptoms like pain, discomfort, palliation is relieving or attempting to relieve the pain and discomfort. So it would be, antibiotic therapy for a long, long time. And unfortunately, the outcome for this, what typically happens is if it's gone too far, and you see this really often with diabetics, that we wind up amputating, which is sad. So if you look at slide 3, you'll see there are pictures of the bone, and it kind of shows you how the osteomyelitis, how that infection kind of works its way into the bone tissue, and then slowly the bone tissue becomes ischemic, necrotic, and once it's necrotic, the word necrosis basically means dead, and at that point, it's a bridge too far, so it's gone on too far. When we talk about osteomyelitis, really, just like everything else when it comes to health, prevention is the key. Maintaining good hygiene, the right type of perfusion. So let me give you some examples. If we're talking about maintaining perfusion, let's talk about diabetes mellitus, because that really is the number one reason that we see all these kinds of adverse consequences. So if a patient is diabetic and they are suffering from diabetic peripheral neuropathy, which is loss of sensation in the lower extremities, the big issue here is they'll get a wound on their foot, and most typically they don't feel it, they don't see it, and then it becomes osteomyelitis. So prevention being the key. Diabetics need to inspect their feet every single day. The bottom of the foot, between the toes, right? Everywhere. If they're unable to see the bottom of their foot, then they need to get someone to help them to inspect their feet. They should never soak their feet, ever. Matter of fact, just keep this in mind. Here's the rule of thumb. Don't soak anything. And don't get in a bathtub. Bathtub is filthy, okay? If the answer is soak the feet or, sit in a warm bath, that's not the answer, okay? So this way, if there's a wound, the diabetic is going to see it by that inspection, and it's going to get addressed before it progresses to osteomyelitis. And a couple other things. Diabetics absolutely should always wear shoes, and they should be closed-toed shoes. You shouldn't wear sandals or slides, flip-flops, any of that stuff. And diabetics should Definitely moisturize their feet. They can use lotion on their feet, but never between the toes. Because remember, there could be a fungus among us. What I mean is, lotion between the toes promotes a moist environment, and it's also usually very warm, and it's usually a little bit sweaty, which can promote the growth of a fungus. And a fungal infection can cause a compromise in the skin between the toes, which then can progress to a wound, which then can progress to osteomyelitis. Right? Got it? Okay. Hand hygiene, I mean, I can't say that enough. That is the number one way to prevent the spread of infection. And if the patient is on medication for an infection or for a wound infection, make sure that they're taking it the right way and that they're finishing it. That's another thing. Non-compliance with therapy to treat a superficial or local infection is one of the major reasons why it progresses into either osteomyelitis or sepsis. And like I said, the therapy typically is long-term IV antibiotic therapy, which is no fun, okay? And that's about it for osteomyelitis. Now we're going to move on to osteoporosis. Osteo of the bone, porosis. It's right there in the name, porous. Imagine a sponge. You know how a sponge looks with the kind of like holes in it? It's porous. And this is what happens to the bone, okay? The bone becomes depleted of calcium and it is unable to maintain its density or its mass. And as that happens, it starts to become kind of like a sponge and it becomes porous and weak. So people with osteoporosis are prone to fractures because of that lack of bone density. And there's something called a pathological fracture. It's a fracture that happens without an associated trauma. So in other words, I just sit down in my seat, crack, and I've broken a bone. Really? That's a pathological fracture. And the bones do become so porous that this is something that they're at risk for. All their bones are affected, but the most common bones, the spine, which by the way is very painful, the wrist, and the hip, okay? So, osteoporosis, what do we do to, make sure that we're addressing the population at risk? So let's take a look at the prevalence. Lots of people have it, right? It's a very, very common disease. Women, particularly post-menopausal women, and that is related to the lack of estrogen after menopause. It's very important for you to know this. So the highest risk population for osteoporosis are post-menopausal women. And, what's estrogen got to do with it, you may ask? Well, that's a really good question. So let me answer it. If you look at slide number 8, gives you a little bit of information about what actually the relationship is between estrogen and bone mass. So throughout your life, your bones are constantly and continually being formed and resorbed. So in other words, old cells are kind of reabsorbed, new cells, osteoblasts, right, are formed. And the osteoclasts are the things that resorb bone. They're regulated by hormones, parathyroid, calcitonin, estrogen, vitamin D. There are other factors as well. But when estrogen levels drop, particularly once menopause is done, and just so we're clear, menopause is when women's reproductive shop shuts down and all essential workers are fired. I'm kidding, but really that's what happens. The ovaries are the gonads of the female reproductive system, just as the testicles are the gonads for the male reproductive system. Ovaries are responsible for a lot of hormones, but the most important one is estrogen. Estrogen is the female hormone that makes a woman, right? And the effect that it has on the bone and the bone being able to resorb and constantly like remake itself with osteoblasts diminishes as estrogen levels drop. If you look at slide 9, I pulled something right out of the Merck manual. And remember, when it comes to diseases, pathophysiology, the Bible of medicine is the Merck manual. It is free. Always use the professional version, by the way. So, with men and women, the highest bone mass, the peak of our strongest bones is right around the age of 30. There are some statistics here with regard to ethnicity, like African Americans versus whites and Asians. And African Americans actually have the edge because they have more bone mass ethnically wise than whites and Asians. Men typically have more bone mass than women. And by the way, they have more muscle tissue than women. Just a fun fact. So what happens is with women, right around when menopause begins, bone loss starts to really speed up. It accelerates. So they lose about 3 to 5% of their bone mass a year for about 5 to 7 years after menopause. And then after that 5 to 7 year period, the bone loss starts to decrease a little bit. But that 5 to 7 year period, you can really lose a lot of bone density and bone mass, which really opens the door for a lot of problems and osteoporosis. So, most common kinds of fractures, hip or vertebral fractures. So, just think about it. How many times have you heard, oh my God, did you hear about Mrs. Jones? She fell and broke a hip, and 6 weeks later, she died. Well, it's not that she broke the hip that killed her. It is the consequences or complications of the surgery that really are the problem. Anesthesia hangs on in older people for a longer time. And just in general, they have a lot of post-op complications. When we're talking about vertebral fractures, remember, your vertebrae are those bones that run up and down your spinal column, and they protect it. And they also give you all kinds of range of motion. And if you don't remember, let me remind you again. Breakfast, lunch, and dinner. You have 7 cervical, you have 12 thoracic, and you have 5 lumbar. If there is a fracture in a vertebral body, one of the vertebrae, it causes a lot of pain. And when you think about older people, they may in fact get a fracture, and they may not be a candidate for surgery at all. So now, instead of worrying about post-op complications, we're worried about chronic pain, disability, immobility. And immobility carries a whole nother set of risks. So, understand that this is really a very serious and significant issue. So what are the risk factors that we can't change? Well, if you're female, right? You can't. Well, let me clarify that a little bit. Can you change your gender? Sort of. But the DNA that you have is still whatever you were born with. So you can't change that. You can't change your age. Believe me, if you could, I would have done it already. Women, particularly that are small boned, petite or lanky. So in other words, tall and thin or petite and thin. They're most at risk. Postmenopause, we talked about that. For men, not as common in men, but low testosterone and estrogen. And yes, men have some estrogen. We have a little testosterone, right? Which is progesterone. But we both have a little bit of the opposite sex's male or reproductive hormones, but in very low quantities. So with men, yeah, low testosterone and estrogen can affect them, but it's not as common. Family history. Your genetics are your genetics. So family history, you're automatically not guaranteed to get it, but you're automatically a higher risk. And if you have a history of fractures, then that's going to put you at risk as well. So these are all things that you need to know. Modifiable. Now, these are the things that we can do something about. If a person has a low calcium and vitamin D intake, that is a big risk factor. So what I've done, if you look at slide 12, I have included foods that are rich in calcium and then foods that are rich in vitamin D. So when you think calcium, you think, cheese, milk, yogurt. But sesame seeds, poppy seeds, sardines, almonds have a ton of calcium. Collard greens, kale, broccoli, okra. And don't forget, fortified oatmeal and cereal. And FYI, ATI does like to say that and give you a question where, what is a high source of calcium? Oatmeal, because they're all fortified. And then vitamin D. Vitamin D It's a fat-soluble vitamin. The fat-soluble vitamins are A, D, E, and K. And you need vitamin D to absorb calcium. So foods that are rich in vitamin D, sardines, salmon, anchovies, mushrooms, fortified oatmeal, and cereal. But you gotta have the sunlight. So, people ask me to explain this, and I don't always do it, but I'm going to do it for you right now so you understand. In your skin, there's a very specific type of cholesterol that actually works as a beginning factor or a precursor to vitamin D. So when it's exposed to ultraviolet B radiation from the sun or from a tanning bed, it becomes vitamin D. Well, you need a minimum 15 minutes a day, 3 days a week. Okay, almost all research agrees on that recommendation. 15 minutes a day, 3 days a week is the minimum that you need. Don't forget that. When I talk about it, you're going to see it again. And then, some modifiable risk factors that also, things we can change. Excessive caffeine, high protein or high sodium diet. Sedentary lifestyle, it'll kill you. You got to sweat. Excessive alcohol use, and cigarette smoking for everyone except for me. So just make sure you know those modifiable risk factors. How do we prevent it? Because remember, with all diseases, better to prevent it than to try to treat it, right? So building bone and muscle mass as much as a person can is important. One of the reasons why I stay in motion the way I do is because, I hate to show off my guns, but, I will just so that you can see them. And let me take a look at the camera and see, right? You want to have muscle mass because that helps protect the bones, right? Muscle and bone interconnected. You have to get enough calcium and vitamin D in your diet. And get your sunshine 15 minutes a day, 3 days a week. Weight-bearing exercises. So remember, when we're talking about weight-bearing exercises, I don't mean yoga, right? Walking is great. Weightlifting is also great. Or you can just come to my house and help me do yard work and, paint ceilings because that's great. Weight-bearing exercises, remember that. Running, bicycling, and swimming, they're not considered weight-bearing exercises. They're cardio, which you need them too. But here we're talking about weight-bearing exercises because they can really help prevent osteoporosis. And, don't drink excessively. Don't smoke. So what are the signs and symptoms? Well, back pain is one, but the most classic sign and symptom that you're going to see with older women particularly, they start to lose height. They start to shrink as they get older. It happens to everybody, but the degree to which it happens really does vary from person to person. So most people will lose a half an inch or an inch of height as they get through their late 50s to late 60s. But some people, you'll see them lose 2 inches, 3 inches of height. And fractures, they start breaking bones, and kyphosis. Kyphosis, the hunchback, right? That's a telltale sign. So make sure that you know those telltale signs when you're assessing a patient. These are things that you're going to be looking for, okay? What are the effects of osteoporosis? Well, deformities like the kyphosis, and then, a lot of other effects, functional, emotional, and social. You're not going to want to go out and see people. You're not going to, be able to do the things that you enjoyed doing in the past that are physical. And that takes a toll on a person's emotional and mental state. So these are all things that we address as nurses because we address the whole person, right? What tests do we do? Well, here's what you need to know. The one thing that is done very commonly is called a bone density scan. It's also known as a DEXA scan, which stands for dual energy X-ray absorptiometry. You don't need to know that. Just know DEXA scan, bone density scan. Basically, it's kind of an X-ray, but what it's doing is it's looking at all the bones in the body and it's looking to see how dense they are. So this is a very common test that's done to see if, in fact, the person either has osteoporosis or is on their way to osteoporosis, so we can do something about it. Serum calcium level and vitamin D levels are decreased, so you want to make sure that you're checking those. Serum calcium, 8 to 10, make sure you know that. Don't worry about the vitamin D levels, but serum calcium, 8 to 10, okay? Serum phosphorus is going to go up. Don't worry about phosphorus yet, and don't worry about alkaline phosphatase just yet. It will come, okay? What do we do for these patients? Well, on page 18, we talk about therapeutic measures. So, of course, reduce the risk. Prevention. Calcium supplements if necessary, vitamin D supplements if necessary. Let me say this. Your body wants to get what it needs from food. Your body does not want a pill, okay? So the best thing that you can do for yourselves while you're young is to make sure that you eat reasonably well. You don't even have to eat a fantastic diet, but if you eat a reasonably healthy diet, you are doing a great service to your body, because I can't say this enough, you are what you eat, okay? So for people that have it, we're going to tell them eat these foods or maybe take these supplements. And medications. So what medications do you need to know? I'm glad you asked, so let's talk about the medications. And there's one particularly that you are going to get asked about. Promise. ATI loves this, and so does the Board of Nursing. It is a biphosphonate drug, and the name of it is alendronate. Trade name is Fosamax. Don't worry about that. Just remember alendronate. Alendronate is a medication that is given to treat osteoporosis. It's taken once a week. It's taken by mouth. The patient must know that they have to take that before anything else. Any other medications, take it by itself. Take it with a full glass of water. Stay in an upright position. Like, don't take it and go, I'm going to lay back down. No, they must stay upright for 30 minutes because one of the adverse effects is erosive esophagitis. So what that means is the nature of the medication, if you're lying down, it's going to work its way through the esophagus, and as it does, it's going to erode the smooth mucosal lining, right, and cause ulcerations, which is very painful, very dangerous. So once a week, by mouth, full glass of water, first thing in the morning. Don't take anything with it. Stay upright for 30 minutes after you take it. Got it? Right? Make it easy. Don't make it harder. And then other therapeutic interventions, there are definitely other medications that we can give. Don't worry about the monoclonal antibodies and selective estrogen receptor modulators and bone-forming meds, not yet. I will tell you this, that for postmenopausal women, estrogen supplements are sometimes recommended, but estrogen carries with it side effects as well. And some of them are really, really significant and severe. So, it's not the first line of defense giving an estrogen supplement. Sometimes it's appropriate. Make sure you know the alendronate. Okay? All right. So, and then the next couple slides go through nursing care and question that you can answer. And now we're going to move on to gout. Gout, I'm going to make gout very short and sweet. The way you remember gout is that we always called it the rich man's disease. Why? Because gout is caused by a buildup of uric acid in the blood. And when the uric acid levels increase, they accumulate, and particularly in joints, and particularly the feet and lower extremities, that cause severe swelling and inflammation. Very, very painful. And it's the rich man's disease because uric acid comes from eating foods with purine in them. And the foods that contain purine are the ritzy foods, right? They're very extra, bougie foods. So what foods are they? Organ meats have the highest. And I mean, you couldn't pay me good money to eat liver, but that's an organ meat. Lots and lots of purine. Wild game. So for people that eat venison or duck or goose, lots of purine. But then expensive things like mussels, scallops, which I love mussels and scallops, sardines, anchovies. Yep, I'm Italian. I love those too. Don't eat them all the time. Red meat is high in purine. all red meat, so steak, ground beef, right? Bacon. I mean, what tastes better than bacon in your mouth? High in purine. And then when it comes to vegetables, not as much, but spinach, cauliflower, and mushrooms do have the highest amounts of purine other than other vegetables. So make sure that you know that. I'm not going to get into the pathophys of this too much. Just understand that most often it's primary and it's just inherited. It runs in families. It can be secondary to other diseases, but don't worry about that. Signs and symptoms, though, got to know. When it's acute, they are going to have swollen, red, hot, and very painful inflamed joints, and it usually starts at the great toe. And oh, by the way, the great toe, when we're talking about digits, so metatarsals and metacarpals. So metacarpals are fingers, metatarsals are toes. If we're describing the toes, the great toe is your big toe, right? We would never say the patient's big toe or the patient's baby toe. We would say the great toe, the second toe, the third, the fourth, or the fifth, just FYI. And with chronic gout, because of that constant accumulation of uric acid, not only do they have the symptoms of acute with the inflamed joints, they get deposits of this urate, which is the uric acid under their skin, and it can even accumulate in their kidneys and cause kidney stones, which, by the way, are painful, okay? Very painful. So what tests do we do? What do you need to know? Serum uric acid, normal, 2.4 to 7, 2.4 to 7. Did I say that? 2.4 to 7. Serum uric acid. If it's elevated, they have too much uric acid, they're probably either they're eating a bad diet high in purine, they're at risk, or they already have gout. And so what do? Therapeutic measures. So when they're in an acute exacerbation, we can give them NSAIDs to decrease the inflammation. But colchicine is the drug of choice. And if we know that a patient is prone to it, then we would use allopurinol. And we're going to talk about these medications later on, so I'm not going to test you on these. That's why I'm not giving you a lot of information about them just yet, but at least I've introduced you to them. But alendronate, make sure you know it. You've been warned. And then as far as nursing care for gout, just make sure that you're teaching the patient what foods they need to avoid, what meds they need to avoid. Aspirin, diuretics. So diuretics, why? Because diuretics, when they start making the kidneys work harder to get rid of excess fluid, patient can get a little on the dehydrated side, and actually it can throw off the balance of uric acid, right? Okay. Alcohol, stress, stress and anxiety. Let me tell you, of all the things that will kill you, stress is up in the top 5. Everyone has stress. Even me, we all do. How do you manage it? If you keep it inside and start simmering like a crock pot, guess what's going to happen at some point? Boom. So manage stress. There are lots of different techniques that we can use. And then make sure you're getting adequate fluid. So again, I'll reinforce this. Healthy adult human. Fluid necessary, 2,500 to 3,000 milliliters a day. Commit that to memory, right? 2,500 to 3,000 milliliters of fluid a day is what you should be drinking. And I don't mean Pepsi or tea. Water, even juice, if it's not contraindicated. And believe it or not, cherries and cherry juice help carry purine out of your system. So, this is one of those old wives' tales that actually is based in science. So cherries, cherry juice, absolutely good for people with gout. All right, and that's all I got for gout. So next we're moving to osteoarthritis. We're going to talk about osteoarthritis and rheumatoid arthritis. Osteo first. Osteoarthritis is it's arthritis. It is the thing that people get as they age, and it is just wear and tear, So you buy a car, and over time, the parts start to wear out, don't they? Well, the same thing happens with the human body. So over time, the parts, the joints, kind of start to wear out from wear and tear, and it causes inflammation, swelling, and pain in the joints. I mean, it says here 30 million people, probably way more than that. If you see something called degenerative joint disease or DJD in a patient's chart, well, it's osteoarthritis is what they're talking about, right? Increases with age and wear and tear on joints. And like I said, it is definitely exacerbated by the cold. The cold. So, when the weather is cold and it's very cold and damp, you will hear older people complain, oh, my back is killing me today, right? And that's because it really does make the inflammation worse because it's chronic inflammation. Keep that in mind. There's a big difference between something chronic and something that's acute. If you fall and sprain your ankle, cold, ice, right? Rice, rest, ice, compression elevation. But if you have a chronic inflammatory disease, like osteoarthritis, rheumatoid arthritis, heat, okay? Heat makes it feel better. The pathophysiology, again, not going to get into this very, very in depth, but just understand that it's just wear and tear. So if we're talking about, say, a knee, over time, the articular cartilage is the cartilage that allows the bones to talk to one another, right? And the ends of them start to basically wear away and deteriorate. So the space inside the joint starts to get narrow, starts to get inflamed, and then the patient will present with joint deformities, joint swelling, pain, and immobility because it hurts to move. And it's usually the weight-bearing joints. So weight-bearing joints, ankles, knees, hips, they're the big characters at play here. Page 33, you can see there's a skeletal representation that kind of hones in and shows you, like a hip joint, how it gets affected by osteoarthritis. All right, what are the risk factors? Heredity. You can't change your genetics. You got what you got. Aging. Can't change that. Obesity. You can change that. Excessive wear and tear. When we say wear and tear, impact. Remember that. With osteoarthritis, jogging, running, aerobics, jumping, that's boom, 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 boom on the joints. High impact. That's going to cause excessive wear and tear on those synovial joints. So it's something that people should avoid. There are lots of other ways to exercise that don't involve high impact. So signs and symptoms are joint pain, which usually gets worse when they move around. And I'm going to add this in. It can get worse as far as stiffness and pain from immobility. Say when they first wake up in the morning, stiff, right? And then there are things called Heberden and Bouchard nodes. You don't need to know what they are. I just left them in there. They're bony nodes that can happen on joints of the fingers that are from wear and tear, overuse. Well, what diagnostic tests? An X-ray is going to show that wearing away of the bone. An MRI, which magnetic resonance imaging, is the most, can't say this enough, an MRI is the most definitive diagnostic tool that we have that can show us inside the body down to millimeters of slices. In other words, we can look at bone, we can look at soft tissue. So MRI uses a magnet as opposed to radiographic images like x-rays and CT scans and stuff like that, which would show bone, but not so much soft tissue. MRI, if you really want to see what's going on inside somebody, MRI is the way to go. And I will add this in. MRI is a magnet, a huge, big magnet. And so pre-diagnostic, you need to find out if the patient has any metal in their body. The only metal that's safe in an MRI is titanium. That's it. So if they have like joint replacements or implanted port or a pacemaker or anything like that, no MRI for them. Have they ever worked as like a welder or anything where there's the possibility they've gotten either glass or metal in their eye? So that's definitely a no-no. And are they claustrophobic, right? Traditional MRI is a big, big machine that you lie in a supine position, and it literally kind of feels like you're in a coffin. So the ceiling of it is right here. And it takes about 45 minutes sometimes longer, sometimes not quite as long. It depends on what we're taking pictures of. And when the patient is in there, very frequently, if they have even a little claustrophobia, they're going to freak out. So it's very important to find out if they're claustrophobic. And what can we do? Well, we can either, the doctor can prescribe a Valium or Xanax, a little chill pill to take the edge off. Or you don't need to know this, but just for your own information, there are things called stand-up MRIs. So it's open, right? The patient sits and, it's not quite the best picture compared to a traditional, but it's better than nothing, right? Okay. So those are things you need to know. And as far as treatment, well, exercise, weight control. I can't say this enough. If you are carrying more than 20% over your recommended body weight for your height, you gotta lose weight. Your bones and your joints are not meant to carry that type of excessive weight, and you're going to suffer the consequences at a much younger age, because there's no cure for osteoarthritis. So what meds do we use? NSAIDs are the big ones, and you better know your NSAIDs: ibuprofen, meloxicam, celecoxib, naproxen. Okay? And heat. Be careful. Heat therapy requires a prescription. You have to be very cautious when you're applying, say, a heating pad to someone. It requires a doctor's order. And not only that, there are some things that would preclude or prevent the use of heat. Peripheral neuropathy. If the patient can't feel or they have a diminished sensation, you're not going to put heat on an area that has diminished feeling, because guess what could happen? They can get burned. Right? Okay. And complementary therapies, yeah, guided imagery, music therapy, acupressure, acupuncture, sure. And then surgery, which is always supposed to be the last resort. They can go in for a total joint replacement, total knee, total hip. Nursing diagnoses are on page 38. Take a look at those, make sure you understand them. And patient education, teach them to protect their joints. If you do it when you're young, then, back when you're young, you don't have problems when you get older, right? So avoid high impact exercises like running and jogging. Participate, and this is important, ATI question, water aerobics or exercises in a pool are the best. Why? Because there's no impact and you're buoyant in water. So it takes the pressure off of all your joints. It's like, you float in water, right? And yoga, stretching, those kinds of things are good for people with osteoarthritis, okay? Don't forget about that water exercise thing. It's important. All right, rheumatoid arthritis, very different than osteo. Rheumatoid arthritis, it's a chronic, progressive, systemic inflammatory disease. In other words, it doesn't go away, it only gets worse, and your whole system is involved, and we really believe that it's autoimmune. Autoimmune means the patient's own immune system attacks their stuff, and in this case, their joints, and destroys synovial joints, connective tissue, can even destroy organs. Very bad. There are literally thousands of autoimmune disorders. Rheumatoid arthritis happens to be one. Multiple sclerosis, lupus, sarcoidosis, so many autoimmune disorders. So just understand that's what rheumatoid arthritis is. Very different than osteo. If you take a look at 41, it kind of shows you what the joint looks like. Don't worry so much about the pathophysiology. What happens is the joints get attacked and the connective tissue gets attacked and they start to get inflamed. Fluid starts to accumulate inside the joints and they start to become deformed. We're going to get to a picture in a second. It's genetic. When we talk about the etiology of it, sometimes there can be some kind of a pathogen that caused it. But it's genetic or autoimmune. I mean, if you're going to get it, you're going to get it, okay? And the signs and symptoms, it waxes and wanes. It comes and goes, remissions and exacerbations. Just make sure you understand that. And that varies person to person. Some people will get it where it's really, really significant. Others, they'll start to have some signs and symptoms. They'll come, they'll go. Well, what do we do? Or I'm sorry, how do we look at the signs and symptoms? Usually bilateral, symmetrical joint inflammation. In other words, if we're talking about the fingers, the joints in the fingers, it's both hands, and they're equally swollen. Bilateral means both sides. Symmetrical, they're even. Asymmetrical means they're not. Reddened, warm, swollen, stiff, painful. Sometimes patients, because it's autoimmune, will have a low-grade fever, weakness, malaise, general lethargy, fatigue, anorexia, loss of appetite. And as it progresses, if it's not treated, they will wind up with deformities of the joints and even osteoporosis that's secondary to the damage that's happened from the rheumatoid arthritis. And then slide 45 shows you, and that's not even the worst case I've ever seen. It's pretty bad, of hands of a person with rheumatoid arthritis, which very, very painful. What tests do we do? Here's the only one you need to know. We do several: rheumatoid factor, anti-nuclear antibody, C-reactive protein, but the ESR, erythrocyte sedimentation rate, this is one that you need to know. Commit it to memory, right? Right up there with your calcium level and uric acid. ESR normal is 1 to 20. And what it is it's a test that's done that basically just indicates systemic inflammation. So you're inflamed somewhere. It's not super specific, and we actually use this test for lots of different types of inflammation, not just rheumatoid arthritis. But it's important that you know that they're going to do an ESR, and if it's over 20, it's a positive, okay? What do we do to treat it? Well, here's where it gets tricky. Because there's inflammation and it's autoimmune, so we can hit it several different ways. I'm actually going to first talk about NSAIDs and corticosteroids. Non-steroidal anti-inflammatory drugs, your meloxicam, your celecoxib, your ibuprofen, your naproxen, will decrease inflammation. Helps. Prednisone, methylprednisolone, corticosteroids also decrease inflammation. Side effects: long-term use of corticosteroids, suppressed immune response, weight gain, moon face, I can go on and on. But, it's risk versus benefit. Everything we do in medicine, if we're giving you a medication, what is the risk associated with that versus what's the benefit? And if the benefit exceeds the risk, we're going to do it. Methotrexate. Methotrexate is an immunosuppressive drug. It's an immunomodulator, and it's used, it's old. It's been around forever and ever and ever, long before I was even a nurse. So you know how old that is. But methotrexate is a drug that ATI loves to ask you about, promise, and also the Board of Nursing, the NCLEX, loves to ask about it. So methotrexate, it's a chemo drug, immunomodulator, decreases inflammation, suppresses the immune response. So if this is an autoimmune disease and your immune system's running amok and going haywire and in overdrive, methotrexate shuts it down. It shuts it down, and that's how it addresses the problem. But shutting down your immune system, think about it, now you're at risk for infection, right? It's myelosuppressive. So what it does is it suppresses bone marrow. Bone marrow is where all your blood cells are made. So not only are you immunosuppressed and you're at risk for infection, your thrombocytes or platelets are suppressed. Now you're at risk for bleeding. Your red blood cells are suppressed. Now you're at risk for anemia. Okay, make sure you know that. And then last but not least, there are new drugs. They call them biologics, anti-rheumatic drugs. Etanercept, which is Enbrel. You might have seen a commercial on TV. That is an immunomodulator drug, but more of a biologic. And all you need to know about that one, it also causes immunosuppression. And we're going to talk more about methotrexate and etanercept, later on. But make sure you know your NSAIDs, right? We talked about those already. Therapeutic interventions, it says heat and cold. Most often cold only if it's really, really warm, if it's a hot joint. right? Balance, rest, and activity. And then if it gets really bad, they're going to need a joint replacement. So, these are things that you should know. And then the last slide, or the second to the last slide, talks about nursing diagnoses, patient education. Remember, what's your role as the nurse? They need to understand the disease. So you need to explain to them, autoimmune, your immune system that's supposed to protect you is going a little crazy, a little haywire, right? You have to make sure they understand that you have to make sure you're responsible to teach them about their meds. What are the adverse effects, like the immunosuppression? When do they take them? Empty stomach, with food, in the morning, at night. Okay? That's why all this is so important. Teach them about rest and exercise. Vocational counselor, in other words, they may not be able to perform certain tasks or certain jobs, so they may need to speak to somebody about a change in their career. And then, you would get maybe an MSW, medical social worker, to refer them to community resources. You are taking care of the whole patient. So that's it. That's all the things that you need to know, but we're afraid to ask. And we are done now with musculoskeletal. Okay? Have a great day and see you next time. Bye.